The following podcast is part of a certified educational activity titled The Itch We Could Never Scratch, incorporating new and emerging therapies to alleviate the burden of prurigo nodularis with a team-based approach. Access the entire activity and complete the post-test at peerview.com/NZV860. Downloadable slides and practice aids are also available.
Welcome everybody to our program today. We are here to discuss Prurigo Nodularis. Our program is The Itch We Could Never Scratch, incorporating new and emerging therapies to alleviate the burden of Prurigo Nodularis with a team-based approach. So today we have our entire healthcare team here to include Dr. Gil Josipovich from the University of Miami, Dr. Adam Friedman from George Washington School of Medicine and Health Sciences, myself, Heather Gates, physician assistant from the Dermatology Institute and Skin Cancer Center in the Villages, Florida. And we also have a patient joining us today to discuss her disease state and burden of disease, treatment options that she has tried, Cheyenne Boulet. We're excited to bring this to you today, so thank you for coming. So here are our goals for today. We're going to help you recognize the impact and the burden of disease on patients' lives from this disease. We're going to improve your understanding of the pathophysiology behind this disease and how it's going to correlate to the treatment that you select for your patients, and discuss novel therapeutic strategies that are emerging on the market. We're going to provide you with the skills to incorporate these new therapeutic options, and we're going to enable you to collaborate with your healthcare team, including physicians, nurse practitioners, physician assistants, nurses, medical assistants, pharmacists, because when we collaborate as a team, patients are going to get the most optimized care possible. All right, so now we're going to discuss Prurigo Nodularis in detail. So what is Prurigo Nodularis and how prevalent is it in our population? Prurigo Nodularis consists of a disease with irretractable chronic pruritus combined with multiple or localized nodular lesions. The prevalence in the United States is over 87,000, which is 72 per 100,000, and this is from 2019. However, if you look at this graph, you can see that over the years, the prevalence has rapidly increased. Now, why are we seeing this? Is this because the use of the ICD-10 code has increased? Is this because of growing awareness? Is it a combination of the both? I think both are highly possible. If we think back for providers that have been around for a while, even over the last decade, awareness has definitely increased. I remember over 10 years ago, we used to tell patients just to stop picking and scratching at their skin, and we would code this as excoriations. But now we know that this is a distinct disease state with specific pathogenesis behind it that can be addressed. You're going to see this more commonly in middle-aged adults. The median onset is age 66, but it can happen at any age. And I will say, where I practice in the Villages, Florida, is an extremely large retirement community. And I think I see this more prevalently than most providers just due to the age range of my patients. And it's something that I very commonly see in my practice. You'll also note that African American individuals are over 3 times more likely to experience this disease than Caucasian individuals. So it's definitely something to keep in your differential when you see nodular lesions on these African American patients. So here are some photos of the clinical presentation of Prurigo Nodularis. So you'll see here, some of these are very extreme cases, but you can have one localized nodular lesion, or we can have a generalized view of multiple prurigo nodules across patients' bodies. And these could be misconstrued for different diseases. For example, with the solo lesion that you see in the middle and the top, some early providers may confuse this for a keratoacanthoma. It could be confused for different blistering diseases. Many things can be on your differential list when it comes to these views of Prurigo Nodularis. All right, so common features that you're going to see on Prurigo Nodularis are typically symmetrical nodules on patient's body on areas that are accessible for scratching, picking, or manipulation of the skin. Most commonly, the telltale sign is this butterfly sign, which you'll see in this photo on the left. Butterfly sign is a complete clearance of disease on their central back where they can't reach to pick or manipulate the skin. It's also significant to note that their face, palms, soles, scalp, and genitals are rarely affected. Along with these prurigo nodules, you may notice lichenification, excoriations, ulcerations, scarring, and also lots of post-inflammatory hyperpigmentation. And all of this is induced by scratching, picking, rubbing, and manipulation of the skin. And these patients are experiencing significant pruritus, which sometimes can manifest as burning, stinging, pain, and other sensations which can disrupt their quality of life. So when patients experience this disease, we get into this snowball and never-ending cycle of pruritus that leads to other issues. So when patients are experiencing constant pruritus or burning, tingling, itching, stinging, they are scratching at their skin, leading to these prurigo nodules on their skin. Because of this irretractable itch, patients are having trouble sleeping. And we'll talk in just a moment about how you can compare this to other disease states that disturb quality of life and disturb sleep. But we all know that when we have sleep disturbance, it also hurts our mental health. And when we have significant lack of sleep for a chronic period of time, this could lead to different psychiatric conditions and psychosocial disturbances. So patients, after some time and they develop these lesions on their skin, can be quite frankly embarrassed to go into public. And this can lead to psychosocial disturbance. They're embarrassed to be seen with these lesions on the skin. They're embarrassed of the way their peers and colleagues may judge them, and this can lead to shame. And again, as we move through this cycle, this can lead to depression and anxiety. And this is a never-ending cycle unless we as a healthcare team help our patients that are suffering from this disease with the proper clinical approach. So you can see here that this slide discusses how much sleep disturbance these patients are experiencing. So the slide on the left is sleep disturbance from prurigo nodularis, and the slide on the right, which is red, discusses the sleep disturbance from atopic dermatitis. And you can see when comparing these two charts that they're nearly identical. So in prurigo nodularis, 61% of patients are experiencing great sleep disturbance, and in atopic dermatitis, 64% are experiencing great sleep disturbance, and so on. So we all know how much our atopic dermatitis patients suffer significantly from sleep disturbance and mental health issues that result from this. And so when you compare these graphs, we can then translate and understand how much these prurigo nodularis patients are suffering from this disease, and it's interrupting their sleep and affecting their mental health. So speaking of burden of disease, this is going to impair their quality of life. Like we discussed, sleep deprivation, embarrassment and shame over these lesions, which can lead to missed work, missed school, missed functions. And this creates an emotional impact. These patients can feel isolated and lonely, and this leads to depression, anxiety, anger, shame. And if they don't have a healthcare team to help with them, it quite honestly leads to a sense of helplessness. And there's many comorbid conditions that can go along with this, whether they're causative or results of the disease. More studies still need to show, but we know that atopic dermatitis and other disease states that can cause itch or have symptoms of itch, such as chronic kidney disease, diabetes, heart failure, and amongst other things, can all contribute or be a comorbidity of prurigo nodularis. So now let's hear from a patient with prurigo nodularis who will share their physical and emotional impact of this disease and how it's affected her quality of life.
My initial symptoms were like the sensation of me being very itchy for no reason, and a lot of dark raised bumps were appearing on my skin. So those were the initial symptoms, and I've always had eczema, so I knew that this was something different. And during that time, I used hydrocortisone because I usually use that for eczema. But yeah, that's all I used, and it had no effect. So well, I only saw one dermatologist at the time, luckily. So, but I did get a lot of different diagnosis. Like I would get that I have scabies or like bed bugs or tick bites or chicken pox. Like they would prescribe me for things like that. So I only had one dermatologist, but the diagnosis took a little while for us to finally get there. I remember when it first started, I would wake up in the middle of the night and I would itch for like 30 minutes to maybe an hour. Um, and that was not fun. And then I would come home from after work or doing anything. Like I would sit on the floor, on my bed, like a bathroom, anywhere like where it just the itch came up, and I would itch for like an hour straight. And even when I was like going to sleep with my significant other, he would notice that I'm also itching in my sleep when I didn't even like realize until like the next morning. I'm like, oh, I'm covered in blood. But yeah, so and I started wearing like longer sleeve shirts, like less crop tops, longer dresses for sure. I wore longer pants. I didn't wear shorts. I didn't wear like short skirts or like short dresses because like all of the bumps would be on my skin. So it's very, very dark bumps that are very apparent. So everyone could see. And I couldn't take hot showers anymore because the heat would make my itches like way worse. And I remember when I was like driving anywhere or driving for a long period of time, I would have to itch like during like me driving, or sometimes I would have to pull over on the side of the road because like the itch was so like unbearable. I couldn't even drive to my destination in one go. So my quality of life was very depressing. Like it was actually pretty sad at the time because it was like my whole world kind of was like, why did this happen to me? Like, why is this going on? And nobody knew, you know? So the quality of life was very sad. And I would get like a lot of comments from like, you know, nurses. Like a nurse said to me, oh, do you have chicken pox? Or like, are you contagious? Or when I got my eyebrows done, they would ask me if I was contagious, or kids would be like kind of reluctant to touch me. So yeah, quality of life wasn't that great.
So, what's on our differential diagnosis? When a patient walks in with multiple nodular lesions on their skin, these are some things that should be crossing our mind if we're unsure of the diagnosis. So, we're thinking of hypertrophic conditions like hypertrophic lichen planus. Of course, atopic dermatitis is sometimes comorbid, but it can also be a differential when patients are scratching at their skin, getting chronic manipulation and friction. This can cause lichen simplex chronicus. Autoimmune blistering disorders could also be in the differential, such as bullous disease, dermatitis herpetiformis, and different perforating disorders can look very similar to prurigo nodularis as well. Also, neurotic excoriations, and again, going back to the increased prevalence, I think in the past we probably have coded a lot of these as excoriations or neurotic excoriations as opposed to using the prurigo nodularis code. So now that we have more awareness, we're coding more properly and specifically and understanding how prevalent this disease state really is. Other skin picking syndromes and habit tick deformities can happen with this. Another thought's lichen amyloidosis, like I said previously, keratoacanthomas. Patients will always think it's an arthropod bite, and scabies is on the differential as well. So how are we going to distinguish between prurigo nodularis and these other differentials that we just discussed? So on histopathology, we're going to see these significant features of prurigo nodularis. We're going to see signs of hyperkeratosis. We're going to see pseudoepitheliomatous hyperplasia, focal parakeratosis, hypergranulosis in the epidermis, which we'll see a slide of in just a moment here, so you can see how it would look underneath the microscope. In the dermis, we're going to see papillary dermal fibrosis, vertically arranged collagen fibers, increased number of capillaries, and also some mixed superficial, perivascular, and interstitial inflammatory infiltrate. So as we discussed, you can perform a skin biopsy, and those signs are what we would see underneath the microscope. And this is to rule out all of those other diseases. If we're trying to rule out some sort of autoimmune, blistering, inflammatory disorder, we may also want to get a direct immunofluorescence. And skin scrapings could be indicated if we're trying to rule out any fungal infections or scabies. All right, so here is our workup. So, with any patient at the initial visit, we're going to do an appropriate clinical exam and review of systems. We're also going to denote the severity of prurigo nodularis. How many nodules and lesions do they have? What is the quality of their skin? Is it dehydrated? How significant is their pruritus, which we're going to discuss in a moment, some scales that we can use to measure this. And also, most importantly, we want to treat the patient and not just the disease. So, what is their burden of disease? Are they having impaired quality of life? Are they having sleep disturbance? Is this leading to mental health issues like anxiety and depression? So, these are all things that sometimes can be overlooked and are very important to discuss with your patient. And then, stemming from this, we need to assess their need for behavioral and emotional support. If indicated, you could order some laboratory tests to rule out chronic kidney disease that could be causing chronic pruritus, liver disease. We can check a complete blood count, make sure everything looks good there. Thyroid, check for diabetes, HIV, hepatitis screenings. Sometimes these aren't indicated, however, and it's really stemming from taking a thorough history and doing a thorough exam and then deciding what's clinically indicated to treat this patient properly. If malignancy is suspected, you could send them for an appropriate workup. And again, biopsy is going to be your best bet if you are unsure of the diagnosis or need to confirm the diagnosis. So here's a look underneath the microscope. So you can see that hyperkeratosis, that acanthosis, the inflammatory infiltrate. So on the left, we're seeing this at 40 times magnification, and it's extremely evident when we zoom in at 100 times magnification. So here are our rating scales for itch. And the beauty of these scales is in most EMRs, they are built into your system. So these are things that I have my medical assistants and my nurses do on a regular basis when I have a new patient that potentially has prurigo nodularis, or especially the dermatology life quality index, the DLQI. I'll do that on patients with any sort of inflammatory itchy disease. So these are really important screening tools that you can use to assess the burden of disease on your patients. And it's important to know that these exist and are out there and are typically built into your EMR. And how do we address these patients as a healthcare team? We're all working together to make sure that we have the best possible outcome for our patient and that we're treating their disease appropriately. So as discussed, all providers, including dermatologists, physician assistants, nurse practitioners, are assessing our patients. We're taking a physical exam. We're coming up with a diagnosis and a treatment plan for them, and we're monitoring all their follow-up. We can even perform procedural interventions that are indicated for them, adjust medication doses, and consult them on comorbidities and burden of disease. Dermatology nurses and medical assistants are also providing patient education. They are doing further counseling on patients' treatment with them and just providing consistent support for them. Pharmacists also play a role in this because when patients pick up their medication from the pharmacy, they typically end up with questions. So pharmacists are there to consult them on side effects of their medications, use of the medication, and sometimes a little bit more disease state education as well.
To Heather's very comprehensive description is that we put a lot of emphasis on skin biopsies, but it really is unnecessary because it's not really, it's a clinical diagnosis in the majority of the cases. The biopsy is mainly to just rule out other diseases, but it's unnecessary.
I would agree with that too. I think that, providers very early in their career would maybe want to biopsy, but I can't even tell you the last time. It's been over a decade since I biopsied prurigo nodularis. It's one of those things where you can just walk in the room and you know the diagnosis immediately. So again, like we talked about, all the lab workup, all of the biopsying strategies, really most of the time we're not going to need any of that, because if you're really aware of the disease state, it's going to be that clinical diagnosis.
I think part of the clinical diagnosis, you mentioned earlier the quality of the itch in that it could be burning, it can be painful. I think it's a come all. I think often these patients describe that itch very uniquely in that it kind of covers all the different descriptors, and it is distinguished from the itch of atopic dermatitis that feels amazing to scratch, the itch of chronic spontaneous urticaria, which is more like a burning itch, or even the itch of arthropod assault, which feels good to scratch for like 30 seconds and then starts to hurt. It really is a smorgasbord of sensations that I think distinctly separates it from other pruritic conditions.
It's a narrow sensitization phenomena, but I can't differentiate that from a topic. I could say that the majority of PN, and I hope you agree with me, is that they are more, the itch is more severe than any other diseases. But there is a component of pain and burning, and you're perfectly right.
And I think when we discuss the pathogenesis coming up here, those origins of the itch are going to make a lot more sense as well. So I think we'll kind of come to that when you discuss that, Dr. Josipovich. All right, so I'm going to pass this over to Dr. Josipovich to discuss the pathophysiology of prurigo nodularis.
Well, thank you, Heather, for the comprehensive description of PN and its comorbidities. And now I'll delve into the pathophysiology of prurigo nodularis. And there is a significant component of major two components. One is a neuroimmune interaction with a impaired type 2 overexpression of inflammation, as well as a overactivity of the neural system. And remember, you need to have a patient scratching to induce these activities. And this leads later on with all this immune and neural activity to increase in growth factors causing the nodules and the scar. And this slide goes a bit more deeper into the mechanisms. And I want to emphasize I'm a guy who dealt a lot with the neural system in skin diseases and itch. And the neural system has here a key factor because both the cytokines can activate the nerve fibers and receptors on the nerves for cytokines, causing the itch of PN and the activity, as well as some neuropeptides such as substance P and activity in neural receptors that induce that sensation. Next, here, I'd like to emphasize that there's not just one type of cell involved in the pathophysiology. We all learn about T cells, but also macrophages. Our group has shown that macrophages secreting the IL-31, that itchy cytokine, have a significant role in the itch and in PN, as well as now we know that mast cells and eosinophils have a role here. And what happens is that all of that induces secretion of different mediators that cause the itch and that activity. And I'd like to point out to a extracellular matrix protein that our group has found called periostein. It's secreted by fibroblasts, and remember, fibroblasts have a role in PN. But what's interesting, it's secreted because cytokines, type 2 cytokines, such as in IL-4 and in particular IL-13, cause the fibroblasts to secrete this periostein. This periostein is activating secretion of IL-31 in macrophages and other cells, but it causes a vicious scratch cycle because, interestingly, periostein can activate directly also nerve fibers by its receptor, integrin alpha beta receptor. And in this study, we found that the itch intensity, what you could see is high in PN, is highly correlated to the dermal levels of periostein. Another aspect of beyond the immune system that works also with the immune system is that the neural system is overactivated. We call it neural sensitization. And this is very common in the patients. If sometimes when they put clothing on themselves, or even when you touch them, a non-itchy stimuli causes their patients to perceive it as itch, and they feel uncomfortable with that. And this relates to a neural physiological sensation called alonesis, which is a non-itchy stimuli causing an itch stimuli, and hypernesis, a mild itchy stimuli, causes an amplified the sensory perception of itch and burning sensation. Interestingly, this is not just in the skin, it goes into the spinal cord and up to the brain. So this neurosensitization is not just unique in PN patients to the skin, but they suffer from other neurosensitization phenomena. We found recently in large population study that these patients suffer higher rates of fibromyalgia, a lot higher odds ratio for chronic interstitial cystitis. It could be 24 times higher, and irritable bowel syndrome. So do remember that if your patients have with PN have these complaints, it's in a way associated with that neurosensitization phenomena that these patients suffer from. Now, after I covered the pathophysiology of PN, I believe it would be easier for you to understand what are the targets for this disease. So clearly, type 2 inflammation has a significant role, and we know now that there are drugs targeting these cytokines such as IL-4, 13, IL-31, as well as the neural component that we've mentioned. And in that case, there's a imbalance also of mu and kappa opioids. Mu opioids are overexpressed in this disease, and kappa opioids are downregulated. There's also, as I mentioned, mediators that are secreted by mast cells and macrophages that could be possible targets for this disease. And now I'd like to present to you a 3D animation that kind of summarized the pathophysiology of Prurigo Nodularis.
Prurigo Nodularis, or PN, is a distinct chronic neural and immune-mediated skin disease characterized by intense itch and nodular lesions. As one of the itchiest skin conditions, PN is characterized by the development of a pathological itch-scratch cycle and neuronal sensitization, leading to disease chronicity independent of the initial disease triggers. Histological examination of PN lesional skin demonstrates dense infiltrates of eosinophils, T lymphocytes, and mast cells, which release a wide range of pro-inflammatory cytokines. Eosinophils accumulate in the dermis of PN lesions, releasing the neuropeptides nerve growth factor and substance P, and exacerbate neurogenic pathways. Eosinophil cationic protein and eosinophil-derived neurotoxin eosinophil protein X, the granular pro-inflammatory components of eosinophil cells, are also upregulated in the upper dermis of PN lesions. Interleukin-4 and vasoactive intestinal polypeptide are additional eosinophilic contributors of PN pathogenesis. These pro-inflammatory and pro-fibrogenic cytokines induce pruritus and erythema of the lesions. T lymphocytes play an important role in pathogenesis through the release of interleukin-31 at the lesion sites. Increased IL-31 expression is strongly associated with itch and a wide range of pruritic skin diseases, with the relative highest expression found in the lesional skin of PN patients. Along with eosinophils and T lymphocytes, mast cells also help maintain the inflammatory response in PN, releasing histamine, prostaglandins, and other itch-mediating substances. Increased expression of the neuropeptides substance P and calcitonin gene-related peptide, neurotrophins such as nerve growth factor and endothelin support the notion of dysregulated neuroimmune epithelial crosstalk, also explaining the neuronal and epidermal hyperplasia of skin in patients with PN. In summary, though the exact pathogenesis of PN is unclear, It appears that increased activity of type 2 immune cells and cytokines, along with certain other immune cells and inflammatory mediators, may contribute to signs and symptoms of PN through interactions with neurons and other dermal and epidermal resident cells. In line with a central role of Th2 cytokines, therapies targeting IL-4, IL-13, and IL-31 have either been approved or are in development, and have demonstrated short and long-term efficacy in treating Prurigo Nodularis, offering new hope for improved patient care.
And now I'd like to turn it over to my colleague and good friend Adam Friedman, who will discuss the most exciting part of uh, treating PN and what's going on with new treatments. So, Adam, it's all yours.
Great. Thanks so much, Gil. And yes, it is extremely exciting that we're even talking about FDA approved or potentially FDA approved therapies for a disease state that wasn't even necessarily considered a disease state until recently. So, thus far, we've heard about the kind of polymorphic presentations that can lead you down different rabbit holes with respect to the diagnosis. We've heard about the extraordinary burden of disease on the patient affecting every facet of life that we probably all take, the three of us probably take for granted. We heard about the emerging unique pathophysiology related to prurigo nodularis that really helps define it as a unique disease. And then I have the privilege of talking about, well, where do we go from here? And of course, talk about from where did we come in terms of the therapies we've used to date to managing this disabling condition. Now, when we think about treatment goals, I think it's important to step back and first think about what does the patient consider their goal when they come see us. I really think there are two broad categories, even though you see three bullets here. One is targeting that somewhat unique pruritus, that kind of come all sensory mishmash. And then also there's the visible appearance, which I would argue for many patients is even more disabling than that pruritus that leads to lack of sleep and all the wonderful comorbidities that follow. But I think it's important to address both, but also to provide realistic expectations with regards to how things will kind of transpire over time in terms of that change in itch, but more importantly, how long it could potentially take to resolve the clinical appearance of disease, which may never completely resolve. So, with my patients, I always start by asking, what do they hope to accomplish with whatever treatment we're going to do? Something it's going to, sometimes it's as simple as, I just want to be able to wear short sleeves to my son's bar mitzvah. Maybe it's, I want to be able to wear shorts this summer. Maybe it's, I want to just be able to sleep through the night without waking up with that horrific itch. So I think it's important to have that conversation because then with that in mind, you can talk through how whatever treatment approach you're going to take. And nowadays, while we have an FDA approved option, which we'll talk about, most options are still going to be off label, and no question being in the dermatology space. The utilization of off label therapies is one of the most fun things we get to do. We are off label bandits, but we need to also speak realistically to our patients in terms of how will these impact their goals? How will it help them get to that goal and across that finish line? And how long will it take to get there? So this is a derived figure from a really wonderful review paper published in the Journal of American Academy of Dermatology in 2021 that I think first and foremost highlights a very important message, which is you can't just focus on neuronal dysfunction. You can't just focus on the immune dysregulation. You got to kind of cover both. And I think there are a lot of treatment failures when you only focus on one piece of this multifaceted condition. And what I'd like you to try to appreciate from this figure is there's kind of a stepwise approach, but you have almost two different staircases, and you are climbing both, hopefully at the same time. Another way to think about it is maybe you're taking a little from column A, maybe a little from column B, but you really need to address both these issues, or unfortunately, your treatment or management strategy will not achieve the intended outcome. And so this can include a combination of immunomodulatory or suppressants. Certainly, I've used a litany of systemic immunosuppressants for these patients, light therapy, and now we have hopefully and will have soon a new fleet of options to manage the immune dysregulation. But we cannot ignore that miscommunication, so to speak, that Dr. Yosipovich so eloquently discussed in terms of that neural sensitization and hyperreactivity that many off-label therapies can help address. But even though you may look at this figure and say, "Wow, look at all the amazing options," because most of these, actually only one listed here is actually FDA approved, the amount of data that we have, and especially clinical data supporting the use of these various drugs, the reproducibility across the spectrum of different demographics afflicted with this condition, and of course safety is going to be quite limited to small sample sizes, which is why we need the FDA pipeline, which really enforces certain numbers of individuals evaluated, hopefully including a diverse subject population, to really say that if you're going to use a certain agent a certain way, that you can expect a certain percent of patients will respond a certain way, and of course, the safety that corresponds with that. Now, we did see a major breakthrough in the world of Prurigo Nodularis with the FDA approval in 2022. But to me, I think one of the greatest strengths of this approval was actually the acknowledgement that Prurigo Nodularis is an independent medical problem. Historically, and I probably my colleagues here can share this as well. In our training, we were always told that this was something secondary, that the patient was causing it, that whether it be due to some underlying comorbidity, some underlying medical issue, renal insufficiency, hepatic failure, hematologic, issues, or was it related to a primary skin problem? Either way, this was something secondary that the patient was contributing to, which often put a lot more pressure and stress on the patient that if they just stopped scratching, then all this would go away, which is absolutely not the case. So, in part, and this is true even beyond Prurigo Nodularis, the first FDA approved drug for any condition is also a validation that it is a condition, and that alone can be therapeutic for patients. So, letting a patient know that what they're experiencing is a true independent condition, that there is a ICD code for that you can bill their insurance for that condition, and that there's a drug meant for them, that alone has, I think, a therapeutic impact beyond the treatment itself. So let's talk about the path to approval, the clinical pipeline for dupilumab for Prurigo Nodularis. So this approval is based on concomitant phase 3 studies, Liberty PN Prime and Prime 2. So what I'm going to go through is actually the pooled results from both phase 3 studies. But I think it's important to note that the phase 2 actually shifted its primary outcome time assessment from 24 weeks to 12 weeks. And the reason for this was that in the first phase 3, they noted a significant number of patients improving earlier than was originally anticipated. So a nice oh wow moment in terms of recognizing that maybe this particular drug can work faster than originally anticipated. And that's a very unusual kind of shift. Usually these phase 3s are going to be identical, but the fact that they were able to shift it earlier, I think really speaks to the importance of finding an impactful approach to managing the disabling condition, but also the efficacy. So speaking again about those various tools used to assess the primary and secondary outcomes. So that itch severity was assessed using the WI-NRS, range from 0, no itch, to 10 being the worst itch imaginable in a 24-hour period. And I don't think the three of us have any appreciation for what that 10 really means to those who are experiencing that 10. Then, as I mentioned, a kind of unique IGA in that we're actually counting nodules. So when you think about someone who would be eligible for this study, meaning an IGA of 3 or 4, so 20 to 99 or greater than 100, and a good percent of patients were in that IGA 4, going from that to having 1 to 5 or no nodules, that is a giant hurdle to really overcome. So really these metrics being utilized to understand how dupilumab works, I think certainly that bar was once again very high. And going from over 100 to even 1 to 5 nodules, I would argue, in my clinical opinion, certainly a clinical success. So here's our pooled data looking at week 12 and week 24. Now, I think some liberties are taken here because when you define your primary outcome, you really can't run stats on any time point earlier. However, here we're pooling the data together. So we're looking at both week 12 and week 24, but we're seeing already by 12 weeks in, those treated with dupilumab, 40.5% have had a 4-point or more improvement on that 0 to 10 scale, 10 being the worst imaginable itch in 24 hours, versus placebo, only 19%, and this was statistically significant. Whereas you continue to see capture to week 24, where it went up to 58.8% of patients, yet the placebo arm stayed static. That those who met that outcome not being treated, granted, it's important to note these patients were on topical steroids or calcineurin inhibitors, so certainly a subset will improve, but we're seeing improvement over time in the treatment arm, but kind of a static, plateau in the placebo arm. When we start to get to our secondary outcomes, once again, even by week 12, we are seeing a sizable group meeting that clear or almost clear, that 0, absolutely no appreciable nodules, or only 1 to 5 nodules from those who are coming from 20 to 99 or greater than 100 versus 12% in the placebo. And that continues to increase week 24, almost doubling, 46.4% in the treatment arm, and maybe a little increase in the placebo group. And then I think, to me, the most clinically meaningful data is that combo. That 4-point or more reduction on that worst itch imaginable scale, and also being clear or almost clear at week 12 or 24. No surprise, those percentages are lower. I would expect that. But still, seeing a signal even as early as 12 weeks, and that increasing, literally almost doubling at week 24, I think certainly is very meaningful. And so when a patient says to us, well, is this going to work? I don't want to be a guinea pig. And we've all heard that from patients. And spoiler alert, if it's FDA approved, they're well past the point of guinea pig. But many of these patients have experienced a lot of these off-label therapies that were really nicely highlighted in that previous slide. And I'm sure there's been a wide variety and diversity of experiences. So there's some skepticism when it comes to a new treatment. But I think having this data, it helps us really impart confidence that there's a good chance that they're going to get some improvement. Because remember, we're only capturing the 4-point or more improvement on that worst itch imaginable scale. We're not talking about 3-point, 2-point, 1-point, all of which could actually be meaningful for the patient. So I think that's something to consider, that there is a percent of patients who still improved, but not to the degree of what the FDA would consider a success. And then in terms of safety, dupilumab having multiple indications, we're quite familiar with the safety signals. Very low in the scheme of things. Actually, when we think about serious adverse events, we saw in Prime 1 a higher percent of the placebo arm, not a huge delta between the dupilumab and placebo arm in Prime 2. Discontinuation rates, to me, is a good marker for treatment adherence as well as satisfaction. So we saw no discontinuations in the treatment arm, but some in the placebo arm. No surprise, given this is a disabling disease and these patients were not getting systemic therapy. And the things to look out for, things we are familiar with in terms of conjunctivitis, and we're getting a better understanding of the pathophysiology that leads to that conjunctivitis in patients treated with dupilumab, but very low rates we're comfortable with, and rates we kind of expect from the other parallel approved pipelines and indications. So nothing new that jumps out in this patient population. So we're also going to go into some of the kind of post hoc analyses of the data from the phase 3 program. And I think that it's important to do these types of studies because they, once again, give us more data as practitioners about how to counsel, but also what to expect when we're using these medications. So I think it's important to note, based on everything we've seen thus far, and I think none of us will be surprised that I'm saying this, is that no question the skin lesion improvement will lag behind the improvement in itch. And I have found that even if, let's say, a patient comes in, regardless of what we're using, and their itch is improved even within 30 days, and you think that's a huge success, they will then hone in on the visibility of the disease. So I think it's important not to assume what's most important to the patients again. It's always about asking, how do you think you're doing? Because we know there will be this lag, but it's about that encouragement to keep them going, encourage them to get to that finish line where they will see improvement of both over time. So let's look at some of that data, the evaluation of whether it be improvement of worst itch imaginable, greater than 4 or more. Um, you know, Gil mentioned earlier about pain. We're so focused on pruritus. Whether it be prurigo nodularis, atopic dermatitis, we forget that these patients experience a lot of pain as well, and that is absolutely true in the world of prurigo nodularis. So looking not only at the improvement of proportion of patients who have significant improvement of itch over time, it's important to look at that parallel improvement of pain, because I think depending on which patient you ask, one might be more impactful than the other, but both will have a tremendous impact on quality of life. And when asked, will certainly result in concerning scores on things like DLQI and other patient-reported outcome measures. What about improvement in itch? We heard about how these patients are not sleeping. I think the three of us probably choose not to sleep because we're type A and we like to advance our own careers. But these patients don't have that option. They're not sleeping. So how is dupilumab improving sleep over time? A very similar pattern of improvement in terms of those seeing that increase in hours of sleep. And that, of course, matches up nicely with DLQI improvement over time in those treated versus the placebo. Okay, so let's move on to what's coming. So as of right now, we have only one FDA-approved option, but more fortunately are on the way. Probably the next one we will see, knock on wood, is nemolizumab, also fondly referred to as Nemo, like the Pixar film. And just like my daughter's performance of Nemo in her school play, the hope and at least what we're seeing is that the impact of this medication will hopefully be very impactful, exceptional, and tremendous. So fingers crossed, no question. Now, we heard about interleukin 31 and its important role in itch, in the pathophysiology of prurigo nodularis. And no question, if you ask any resident, what is the itchy cytokine, they will immediately say IL-31, and rightfully so. However, it's important to note that IL-31 plays a role in other activities, such as fibrosis, as an impact on keratinocytes and in the dermis. So I think it's important for us not to have blinders on that IL-31 can be multifunctional, but certainly it is best known for its role in the mediation of itch. So we have a phase 3 program, and we're getting really close in terms of really the evaluation of that data to, once again, I'm using this kind of this imagery of getting across the finish line, which Nemo certainly is certainly near that point. And so here's the data from the phase 3 program, peak pruritus numeric a rating scale, looking at the percentage of patients with a response. We're seeing a delineation, a delta at early as week 4, 41% versus 7.7%, and that climbs all the way to week 16. In a similar fashion, we are seeing the steady rise in the investigator global assessment scale, percent of patients hitting that outcome as early as 4 weeks, 9.8% versus 1.1%, but then climbing to as high as 37.7% in the treatment arm versus 11% in placebo. So certainly a nice kind of parallel between the IGA and then, of course, the reported itch over time. In terms of safety, in terms of looking at what, serious adverse events, less in the Nemo group, adverse events leading to treatment discontinuation rates, percentages actually analogous in placebo versus the Nemo arm. So overall, a well-tolerated medication that seems to have a nice clinical impact. Last but not least, nalbuphine, which is an interesting drug in that it is a kappa opioid agonist and partial mu opioid antagonist with the purpose of mitigating some of the expected side effects of an opioid agonist. And so this is certainly in an earlier phase than obviously our FDA-approved option, dupilumab and nemolizumab, which is sprinting to that finish line. But certainly some early signals that this could have an impact on itch in these patients. Certainly more to come. But the mantra here is more options, less problems, or at least I hope that's the case in terms of having an armament with data that really supports our utilization of said armament. And it would be unfortunate not to mention the kind of up and comers, and I think some of these were mentioned in that kind of pathophys slide, where various interventions could be really seen in terms of where they'd be working. So a fleet of both topical and systemic JAK inhibitors are currently being investigated. Topical ruxolitinib cream is in a phase 3 program currently, where the oral versions are still in phase 2. But I think the take-home message here, and how would you take this slide and translate it to your discussion with the patient, is that hope is on the way, that many FDA-approved options are hopefully going to be in our back pocket relatively soon, which means that people are paying attention to this disabling condition, and that, I hope, is at a minimum validating to the patients. But with all that said and done, the most important perspective is that of the patient. And so now we're going to hear from our patient with prurigo nodularis on her experience with PN treatments.
All the topical creams that they were giving me wasn't working. So luckily, I was placed on a study at some point, and I would have to take injections for 2 weeks, like once every 2 weeks. And I remember I would get maybe a little bit of pain here and there, but I was just so happy, like something was relieving my itches. So it would last about, I think the study lasted for about 7 months. And then at this time, my dermatologist, she kind of left me high and dry after the study was over. And I went through the same motions again of me itching for a very long time. And then I finally went to another dermatologist, and luckily, like, he's great. Like, he really helps me, or they even put me on another research study. Everything was fine after that. But there was no side effects, no anything. I just know that I itched way less, and it was very peaceful, and I could finally work on my skin because of all the dark, bumps on my skin. So, well, I would say take a lot of cold showers when you feel very itchy. Because I used to do that. I would say get a lot of cooling lotion, or even aloe vera, or like Vaseline to help with all the cuts and everything, because I know Vaseline with like cocoa butter has like healing properties. And I always say wear sunscreen, because sunscreen is such a big helpful, like, it's so helpful for me and my skin now.
Okay, now to wrap it up, we're going to have a little bit of a discussion about how we manage prurigo nodularis. And while all three of us see a good amount of this, I imagine our approach is very different, given the fact that we only have one FDA-approved option, though I'm sure that has changed our perspective and approaches since 2022. But I guess maybe the starting question, and I can start by answering it, in terms of when to integrate biologic therapy or any of these strategies into practice, and how do we get patients comfortable with it. I think even in that first visit, I spent a good amount of time talking about what are the options, notably having only one FDA approved option. That's the first drug I'm talking about how it works, what to expect with it, what are the safety implications. I think one of the useful things, while it is only approved for 18 up in prurigo nodularis, I do let patients know that it is approved 6 months and up for other indications like atopic dermatitis, and that usually ends the safety concerns right then and there for most patients. But I am very quick to reach to systemic options. It'd be very unusual for me not to employ a systemic option even on day one, because my experience is a lot of topicals don't work, except for very focal disease with what I call the Yosipovich cocktail, which I'll allow you to talk a little bit about. But I would say 99.9% of patients are getting something systemic. I'll pass it on. Heather first. What is your thoughts on my stating? Go systemic or go home.
Okay, so I'm on the same page with you. For any like inflammatory, itchy disease state at this point in my career, I'm very, very quick to go to a systemic therapy, because otherwise you're just dragging out the inevitable most of the times. I feel, if a patient is very, very adamant about not wanting to do systemic, fine, that's fair. We'll try some topical therapies. But once you sit down and you really explain to them the way this disease state works and the way these medications work on it and how quickly they could improve with all the safety data that we have nowadays, it's very, very easy for me to get these patients on the appropriate systemic therapy. And I think also, to your point that you made earlier when you discussed, 24 weeks it can take for some of these lesions to resolve. I think once you tell patients that, they're like, well, I've had this for years, so what's another 6 months? Like, that is not even bothering them as long as you let them know that's the expectation. It's all about conveying those expectations. But yeah, I am a bit of a biologic cowboy. And you said, what did you say earlier? Something about being an off label bandit. I find so much joy and fun in trying these off-label therapies with patients. And I think when you explain it to them too, like, they kind of get excited because they feel like they're making a change in the disease state and contributing to improvement. So that's my theory on it.
Dr. Yosipovich?
Yeah, I fully agree. I mean, in this case, clearly, uh, the majority of the patients that come to our clinics don't have just one or two lesions, but you could argue that you can give my compounding potion of KAL, ketamine, lidocaine, amitriptyline. The majority need a systemic drug that is effective, and clearly, dupilumab stands on that. I'm very excited about nemolizumab because it would be the next one, hopefully this year or early next year, being approved, and it will also add to our uh, treatment armamentarium because it's clear that that drug works very rapidly on that itch. And remember, that's the major problem that the patients face. Although I know the lesions are disfiguring, but really the major issue is that itch and burning sensation. And these drugs work very quickly to the point of using drugs working on the neural system. So I mentioned that the neural system is very important, but unfortunately, they can't really compete with the biologics. So they would reduce the symptom, but as you've nicely shown in the study with nalbuphine, apparently at the moment there's no drug targeting the neural system that has such a robust effect like a biologic. So in the future, there is a possibility that patients have a more subtle disease or a itch that they don't want the biologic and they want an oral medication. That's a possibility. But clearly, to me, the biologic era of targeted treatment for PN has changed the trajectory of a majority of these patients. I would mention also that there are PN patients who have systemic diseases such as chronic kidney disease and liver disease. They were not tested in these trials. I suspect that it would work for them, but we'll need to, in real world data, to see whether it works similarly. And if not, then we'll have to kind of target more of the neural component of it.
Yep. I'm so glad you brought that up because I think it's almost like there's primary prurigo nodularis and secondary prurigo nodularis associated with some underlying condition. And you're right, a lot of work was done to exclude those patients to really focus on those primary patients. Though in my limited experience with those patients who have underlying disease that you could easily say, "Yep, this is your classic secondary PN because of something else." I've had success using biologics in those cases. But you're so right about if you just focus on the nerves, it's not going to cut it. And I think our more traditional immunosuppressants were so broad, they really weren't hitting on the immune mediators of itch, where now we have those precise therapies that are going after things like interleukin 31, IL-4 and 13, that they actually, a one drug kind of hits both. And that's really ideal that we are limiting how many things our patients are on, because patients have a set capacity for the number of drugs we will give them. And we used to give these patients a ton of different things, and now it's really become much more focused, and hopefully doesn't take up 2 pages that they bring in to show you of things they've tried. I think given we have this, kind of new era of approved therapies, hopefully coming soon, we obviously have this giant bag of off-label options, which when combined can certainly be effective, but to some degree. Even with all this, I think the understanding and appreciation for this condition, even within dermatology, yet even beyond, is limited. How do you think we can get the word out better in terms of recognizing the condition, educating the public more about this condition? I mean, we've seen this story with other kind of orphan diseases from a visibility standpoint, like hidradenitis suppurativa, primary hyperhidrosis. What can we do to foster better communication with our colleagues and, of course, the community to provide support for these patients and also get them into the right places?
So I'd like to take that actually. I think cross specialty education and communication is so important with this. So if we think back to hidradenitis suppurativa, for example, before we had FDA approved treatments for it, these patients would go into urgent cares, family practice, ERs, and everyone would just think it was abscesses. They would drain it, throw them on an antibiotic, send them away. And then these patients are just consistently returning for drainage of these abscesses because they're not actually recognizing the underlying systemic disease state. And I think the same goes for this. I think to this day, if patients go into, their PCP, the PCP is going to say, hey, just stop picking at your skin still. Even the most astute PCPs, primary care providers, they're not educated enough on this disease state because it's not a mainstream disease even in dermatology yet. So I think, presenting this disease state at different educational events for cross specialties is so important. And also when the patient comes in has been told they're just picking at their skin before, educating them that this is an actual disease state, giving them a handout that they can take back to their primary provider and explain, hey, my dermatologist told me this is what I have.
And doing programs like this.
Yeah, exactly.
That was a nice segue.
I'm happy that Heather joined us because the NPPAs are on the forefront of treating these patients in many clinics outside of academic institutions. And it's important that they feel comfortable in treating these. These patients were a lot of times shoved out by dermatologists saying them, okay, take this antihistamine, which we didn't, it didn't work, or take these steroid creams or injections. And they felt really neglected, and I think that the fact that now we could explain to physicians and nurse practitioners and PA that we have safe drugs that are targeted for this treatment makes a big difference.
And I will say, after these patients have been given all these creams from so many different providers, when they come into your office with that Kroger bag or Publix bag filled with their multitude of creams, that's a telltale sign it's time for systemic therapy, hands down.
You're from Florida when you say Publix.
Oh, yeah, it's what it is here.
The gallon size Ziploc bag of what almost looks like toothpaste rolled up, but it's actually topical
Yes.
steroids.
Yeah.
That is, you're right. That I agree. That is a very good sign that you need to roll up your sleeves and start gunslinging and make sure you're really treating this aggressively and with systemic agents. Completely agree. All right. Well, thank you both for those amazing insights. And I hope that on the heels of that statement of better communication and education across all specialties of medicine, that this program really achieves that. We discussed that the goals of treatment for prurigo nodularis is not one or the other. It is targeting that pruritus, getting it under control, which then in turn will ultimately improve the appearance of disease, which could be more or equally as disabling. And by doing so, improving the overall quality of life of these patients and getting them back to the things that we get to do on a daily basis and not to think twice about. We do need an interprofessional approach to really managing these patients, as we know that prurigo nodularis itself can directly result in comorbidities, especially psychiatric comorbidities. We know there's a higher risk for substance abuse, self-medication. And so we sometimes do need a village to manage these patients and get them on the right track. And the treatment landscape has no question evolved and is currently evolving with the very first approval of an FDA approved medication for prurigo nodularis only in 2022. A little late, but we're more than happy to welcome it, with many more on the way, hopefully coming to a store near you relatively soon. because our off-label options, while certainly are fun to use, they are limited by the generalizability to all PM patients, and as well as the data we have to support their use, of course, married to limited safety data. So I think the future is extraordinarily bright for this large patient population, which I would argue is much larger than we actually know of. But also, it makes it even more fun to be a dermatology practitioner because we have more options to get our patients looking and feeling better. Thank you so much for joining us.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Sanofi and Regeneron Pharmaceuticals. To access all materials for this activity, visit peerview.com/NZV860.